Hi, my name is Amy Braglia-Tarpey. I'm a registered dietitian, certified nutrition support clinician, and director of clinical growth for Gus Gear. Today, I'm going to tell you about the use of a central line vest to prevent catheter complications and help you to learn a little bit more about comprehensive securement. On the screen, you can see the learning objectives for this presentation. By the end of the video, you should be able to define primary securement or stabilization and secondary securement based on the Infusion Nursing Society standards of practice. You'll be able to compare the complication rates across different types of securement devices for central venous catheters, review the current data on the central line vest and its use, as well as future research needed, and list the benefits of a vest-type secondary securement device. Central venous catheters are an essential device in the delivery of medication and nutrition for children with a myriad of diseases, from cancer to short bowel syndrome to cardiomyopathy. Unfortunately, this lifeline is not likely to last forever. CVAD failure or removal of a central venous catheter prior to completion of therapy occurs at a rate of 25% and is precipitated by a variety of complications. These include line fracture, central line associated bloodstream infection or CLABSI, and line occlusion, among others. The CVC fracture is a break in the sterility of the line that allows leakage as a result of a tear, hole, or shearing injury to the external line tubing. A retrospective cohort study published in 2019 by Zenz and colleagues at Children's Hospital of Wisconsin found that 29% of children with CVADs had at least one CVC fracture requiring repair or replacement during the study period. CLABSI is a primary bloodstream infection that develops in a patient with a central line where there is not an alternate source of infection and is confirmed by blood cultures. Occlusion is a temporary or permanent inability to aspirate blood or infuse through a lumen of a vascular access device. The majority of occlusions are thrombosis-driven. Each of these complications contribute to a high CVAD failure rate. This is exceptionally troubling for patients with long-term vascular access needs, including those on dialysis or long-term parenteral nutrition, or for extensive cancer therapy. While CLABSI rates have vastly improved over the last several decades, CLABSI still poses highest mortality risk of the CVAD complications. Line fractures and occlusions are less devastating, but occur far more often in those with long-term CVADs and result in unplanned emergency department or clinic visits, decreased quality of life for patients and families, and increased risk of CLABSI itself. In order to prevent line complications and ultimately CVAD failure, stabilization and securement of the line over its lifetime is a critical measure. Line trauma is an umbrella term that applies to line fractures, fissures, and dislodgement. Not only does line trauma potentially increase CLABSI risk, it results in considerable healthcare costs to repair or replace the line, even more so if CLABSI does occur. The numbers you see on this slide are conservative. Other recently published estimates of pediatric CLABSI cost range from $10,000 to $70,000 per episode and result in a length of stay increase of up to 21 days. Current standard of care for pediatric line stabilization and securement initially involves sutures and extensive use of adhesive dressings, which can result in medical adhesive-related skin injury, or MARSI, adding additional interventions and potential threat to quality of life. A variety of securement devices are available to mitigate line trauma and other complications. To quote Gregory Shears, anesthesiologist and vascular access expert at the Mayo Clinic in Rochester, Minnesota, decisions related to securement should be considered equally as important as the choice of the catheter itself. Yet many times the securement choice is ineffective, especially in pediatric patients who may be pulling on their own lines or be more prone to accidental pulling and tugging due to high activity levels or inherent risks in the hospital environment, such as transport. It's important to define and differentiate between primary securement, which is also known as stabilization, and secondary securement. primary securement anchors the catheter to the skin, preventing movement and maintaining catheter functionality. Secondary securement refers to additional anchoring of the infusion set tubing to reduce any force to the primary securement when pulled or tugged. The authors of a large pilot study of securement devices say that the ideal CVAD securement and dressing should prevent accidental removal, micromotion, and pistoning, block bacteria from entering the wound, have antimicrobial properties, assist with hemostasis, be comfortable for patients, be easy for staff to use, and be cost-effective. That is a tall order. Advantages of proper securement are many and are listed on this slide. For those with long-term CVADs, foremost may be the preservation of vessels and vascular access, along with reduction in CLABSI risk. In children, fracture is a more prominent complication that proper securement may help to prevent. There are additional potential benefits which are not as easy to quantify. Proper securement potentially reduces missed infusions, as well as staff and nursing labor, while increasing time to dressing change, parent satisfaction, and parent and patient quality of life. As technology advances, choices for securement have increased. Suture-based securement remains the standard of care for stabilization in most children's hospitals, along with the tunneled cuffed catheter. Most commonly used devices for primary and secondary securement have an adhesive component, which increases risk for skin injury or MARSI in vulnerable patients. Adhesive dressings include transparent dressings and bordered dressings, among others. Integrated securement devices add on a stabilization device to an adhesive dressing. Tissue adhesives are essentially medical-grade glue which seal the exit site and stabilize the catheter. Subcutaneous anchor securement systems are newer devices and are inserted subcutaneously at the time of line placement. A fifth category, sutureless securement devices, have an adhesive background with a stabilization piece. Secondary securement options for centrally inserted lines include tape, adhesive securement devices, and central line vests. It's important to keep in mind that sometimes no secondary securement device is used, even though it is recommended in the INS standards of practice. This omission increases risk for central line trauma and infection. Let's take a look at the properties of the readily available securement devices in the U.S. Adhesive, sutureless, and integrated securement devices reduce the risk of dislodgement. Tissue adhesives add the benefits of reducing line damage and breakage, as well as pistoning or movement of the catheter within the vein. Subcutaneous anchor securement systems reduce dislodgement and breakage and have no adhesive component, thus mitigating MARSI. Central line wraps, or CLWs, confer similar protection to SASS, but do not protect the entire line. Central line vests, or CLVs, reduce dislodgement and line trauma and also protect the entire line from catheter to hub. Vests have no adhesive component, helping to decrease skin injury. However, vests are not as commonly used as other available options. So what does the literature point to as the best device for securement? In an attempt to answer this question, John Bell and colleagues performed a systematic review of 39 studies of traditional securement devices used with adult and pediatric CVADs, inclusive of both peripherally and centrally inserted lines. Sutureless securement devices were excluded from the study, as were central line vests. Subcutaneous anchored securement systems perform best in mitigating migration and dislodgement, but in the bottom half for CLABSI. Conversely, tissue adhesive demonstrated lowest incidence of CLABSI, but had higher rates of migration and dislodgement. If you drill down further to review pediatrics in isolation, there's a significant paucity of data. 6 studies looked at securement in centrally inserted CVADs, with only 2 comparing different securement interventions. Those 2 randomized controlled trials were by the same research group, one in a pediatric critical care short-term population, and one in a longer-term, more generalized pediatric patient group. This is the first of those papers. An Australian feasibility pilot study compared securement devices with tunneled centrally and femorally inserted CVADs in 48 patients in a single-center randomized controlled trial. All securement devices except tissue adhesive were paired with sutures. So you can see the different securement devices here. So here we've got a bordered polyurethane dressing with sutures in A. In B, we've got a sutureless securement device paired with a bordered dressing. In C, you've got your integrated securement device. And in D, you have your tissue adhesive. What they found was that there was no significant difference in failure rate between groups. Interestingly, parent and staff satisfaction with securement devices differed, as you can see they're circled in red. Parent satisfaction scores were highest for the integrated securement device. Notably, ISD also had the highest time to first dressing change and lower non-routine changes than standard care and SSD. Given that dressing changes may distress the child and thus the parent, the time to dressing change may be a contributor to parent satisfaction. Not surprisingly, staff satisfaction was highest with standard care, perhaps owing to a greater comfort level and familiarity. The authors concluded that further research is needed to compare securement devices, and that in the interim, choice of securements should be individualized to patient needs. Investment in more expensive CVAD securement devices is likely to be cost-effective if significant improvements in CVAD complication and failure rates can be attained, and future research needs to investigate this, said the authors. Central line vests were not included in any of the previous studies, though the Children's Hospital of Pittsburgh Intestinal Failure Clinic and Emergency Department teamed up for their own study to evaluate efficacy of the vests in preventing line trauma and infection. This study compared 12 months of data in 6 children with central lines prior to using the vest to 12 months of data post-vest use. Additionally, they looked at 12 months of data in 4 children who received the vest at time of central line placement. All children were diagnosed with intestinal failure and required central lines for parenteral nutrition. In the group with pre-vest data, line trauma and infections significantly decreased after vest implementation. Additionally, line replacements, ED visits, and hospital admissions all trended down, although not reaching significance. In the smaller group receiving vests at the time of central line placement, line trauma incidence rate was similar to the rate in the post-device group. There are currently 2 central line vest clinical trials underway in the United States. The first, at Children's Medical Center in Dallas, is titled Exploration of Central Venous Catheter Protective Devices in the Pediatric Population, a Mixed Method Study. This is a prospective observational study that hopes to enroll 30 patients. Their primary endpoints are parent satisfaction with the central line vest based on a survey, nursing vest feasibility, and a survey of nurse satisfaction. A second clinical trial is wrapping up data collection and will be published shortly, and it's called an innovative central line securement device in the pediatric population. This is a prospective randomized controlled trial of the central line vest, and its primary endpoints include line breaks, line dislodgement, and line inflection. The Children's Hospital of Pittsburgh study will also investigate quality of life measures, including changes in parental stress, child activity level, child sleep, child schooling, child extracurricular activities, and family travel. Now that you've enhanced your knowledge of securement, I want you to meet Bridger. This 8-year-old patient was diagnosed shortly after birth with failure to thrive, gastroparesis, and pseudoobstruction. Keeping him sedentary did not avoid line trauma episodes. Over the course of 3 months while using his current standard of care, they suffered 2 CVAD replacements and 15 CVAD breaks, resulting in 3 hospitalizations, including a 2-week stay in the ICU due to an episode of sepsis. For the family, the emotional trauma was devastating, and the cost burden to the institution exceeded $300,000. Over 2 years later, after starting to use the Gus Gear Central Line Vest to secure the CVAD, the family reported no CVAD line damage episodes, even during activities like riding a bike, jumping on a trampoline, riding all-terrain vehicles, and climbing trees. Bridger's mother said, "The Central Line Vest gave us our life back." So what have we learned today? Stabilization and securement of the central venous catheter is crucial to reduce migration, dislodgement, infection, and other complications, which are exceptionally common in the pediatric population. Securement device efficacy has not been well studied in pediatric patients, however, and clinical trials to date show no significant differences between most of the devices in their primary endpoints. The secondary securement device is recommended by the INS, but sometimes is not used. The Central Line Vest is an alternative non-invasive securement option with preliminary data demonstrating reduction in line trauma and infection with its use. And lastly, additional prospective trials are needed to better understand securement efficacy. Why accept the unacceptable when Gus Gear is available to provide comprehensive securement of CVADs? Scan the QR code to schedule a virtual demonstration of the Central Line Vest today.